The most fascinating facts about pulmonary hypertension, my beloveds, is that it's often called the silent killer of the right heart. Unlike systemic hypertension, essential hypertension, for example, which affects the left side of the circulation, pulmonary hypertension specifically targets the pulmonary arteries, the vessels that carry blood from the right ventricle to the lungs. At first glance, it might seem like a rare condition, and primary pulmonary hypertension is like this. But secondary, in reality, pulmonary hypertension is the final common pathway for many diseases, from congenital heart defects and chronic lung disease to left-sided failure and autoimmune disorders. What makes it particularly intriguing is the vicious cycle it creates within the right heart. So, in pathophysiology in simple terms, when the pulmonary arteries narrow or stiffen, sclerosis, the right ventricle must pump harder to push blood through the lungs. Initially, it hypertrophies to compensate, but over time it begins to dilate and fail, leading to right heart remodeling, right heart failure. This progression explains why patients may initially present only with dyspnea or exertion, but later develop syncope, peripheral edema, and ascites. The most interesting fact is that the symptoms often appear only when pulmonary artery pressure has doubled or tripled from normal. Of course, it's a chronic, one of the most common, right heart disease, right heart failure. It's a chronic obstructive pulmonary disease, so problem of smokers. So the pulmonary circulation is designed to be low pressure and highly compliant. So the disease silently progresses until the compensatory mechanisms collapse, fail. From a diagnostic perspective, echocardiography is the first clue showing right ventricle hypertrophy or dilated pulmonary artery, but right heart catheterization remains the gold standard for confirming elevated mean pulmonary artery pressure, i.e. more than 25 mercury at rest or more than 20 mercury in updated guidelines. Treatment has evolved dramatically in recent years. In addition to managing the underlying cause, we now use vasodilators such as endothelin receptor antagonist, phosphodiesterase 5 inhibitors, sildenafil, and prostacyclin antagonists, prostacyclin analogs, which targeted the molecular mechanism of vasoconstriction and vascular remodeling.